I'll just kind of talk a little bit about some of the inroads we've made into really trying to carve this out as a treatable trait, or as a phenotype or endotype in COPD. And so just disclosures, have some NIH funding, and then some contracts to do research with some industry partners. And I've been a consultant for several groups. The only thing that's really relevant for this talk are the NIH, some of the NIH grants. And just as a general overview, I want to kind of just talk about some and kind of refamiliarize you guys with some of the public health impact of COPD, and then to talk about pulmonary vascular disease and pulmonary hypertension, and kind of what that is, and why it's relevant in COPD, and then spend quite a bit of time talking about some of the different ways that it's diagnosed, invasively and non-invasively, and then spend some time talking about one of the research metrics that we've come up with, and kind of using CT scanning, and then kind of briefly just touch on the therapeutic options and kind of some of the future directions for where we think things are going with this. And so, many of you are familiar with this. COPD, it's defined as a preventable and treatable disease. It is the pulmonary component, or the pulmonary function testing component, is defined as airflow obstruction that's not fully reversible. So that's where we use our PFTs. And typically, the pulmonary function decline is progressive, and it's associated with abnormal both local pulmonary as well as systemic inflammatory responses. Most commonly, we think about cigarette smoke as being the main driver for this, but there are lots of other causes, genetic causes, biomass fuel exposure, other occupational related things can also lead to chronic obstructive pulmonary disease. And then one of the newer things that's been added to the definition of COPD is just the significant extrapulmonary effects that really contribute to the severity that individual patients have. And that's, that and some of the other things that we'll talk about are really kind of what spurred my interest in pulmonary vascular disease. The COPD is the fourth leading cause of death in the United States. And over the last, 50 years or so, there have been a lot of major advances in the treatment of chronic conditions, just as far as general health, cardiovascular disease, diabetes, cancer, et cetera. And all of these we've seen a good, a positive benefit and an improvement in mortality over time. However, COPD remains to be one of these outliers that the mortality has continued to increase over these same decades, and that is even with development of several different respiratory medications. So that just suggests that there are some other drivers for this mortality signal. And one of the major key events that happens in the natural history of COPD are COPD exacerbations. And so these, just as a frame of reference, are defined as an acute change in patient symptoms. So an increase in shortness of breath, cough, and sputum production, sputum purulence, that warrants a change in therapy. And so, when we're seeing this, a lot of patients with COPD, they may have some chronic dyspnea or chronic cough, but when things get worse, typically they'll call their provider for a course of antibiotics or steroids or both. And really these events may be mild enough to be treated on the outpatient side, but a significant portion require hospitalization or supplemental oxygen use. And COPD exacerbations account for over half of the $18 billion a year that are spent in the total cost, direct cost of care for COPD, not to mention the indirect cost of loss of job and loss of work productivity and other things. These are very tightly associated with mortality. So when patients are hospitalized with a COPD exacerbation, several different studies have, over the last, 15 to 20 years have shown that there's a pretty substantial mortality. So the 1-year mortality has been estimated at anywhere between 20 and 35%, depending on the different cohort. And the 5-year mortality is over 50%. So, when patients are hospitalized for the first time with a COPD exacerbation, that is a sentinel event, and it really needs to, a lot needs to be done to really try to help, change that trajectory. And for people that have a COPD exacerbation, following one of these events, whether it's caused by cardiac ischemia, an infection, a viral infection, pneumonia, pulmonary embolism, all of these other precipitants can lead to an exacerbation. But even for those that recover from it, there are pretty significant impacts on lung function. There's an accelerated loss of lung function after an exacerbation event, and reduction in exercise tolerance, and a huge impact on quality of life and other things. And so these events are the most, probably the most important events to try to work at trying to prevent if at all possible. And this is just for me to kind of display that, from a prevention standpoint, this sort of mirrors the longer term data for, management of chronic diseases. This is looking at hospitalization rates for some of these chronic conditions. And so you can see in the different black lines, different conditions like acute myocardial infarction, cancer, heart failure, pneumonia, those types of things, with advances in medical therapies and other processes of care, we've seen a reduction in hospitalization rates. Contrast that with COPD shown in the red line there, where we really haven't seen any change in the rate of hospitalization, which really underpins this problem of excess mortality in this condition. And so when we're thinking about this, I mentioned the mainstays in treatment are steroids and antibiotics for COPD exacerbations, but that may not be a one-size-fits-all for patients. And so, this was a really interesting commentary that came out when I was actually a medicine resident right before I started my pulmonary fellowship, and this really probably shaped my general interest in wanting to really dig in and try to identify things. And so this was Steve Rignard, who used to be at the University of Nebraska, really wrote this pretty interesting piece thinking about should COPD be considered many small orphan diseases just based on the broad heterogeneity of the condition. And I would encourage anybody who's interested in COPD to read this, because I think it's very insightful and really still holds up today. But they were really the first to try to think differently about really thinking about targeting different phenotypes and exploring different phenotypes within COPD. And so this was one of the reasons that I got interested in understanding pulmonary vascular disease. This is some work from the group up at Harvard. That's the Bode Collaborative. And so this is called the Morbidome. And so this was a group of several thousand patients with COPD, and they just looked specifically at different comorbidities. And so what's shown here is each different comorbidity, the size of the different circles represent the overall prevalence in the population. And then the closer it gets to death, which is in the center of the circle, is an increased hazard ratio for death. And this black hatched line is kind of the circle of death, if you want to think about it that way. So anything that's a statistically significant hazard ratio. And so what you see are there are several different groups, in particular cardiovascular, pulmonary vascular disease, heart failure, some other metabolic conditions, some women's health issues, which actually it's pretty interesting in and of itself, kind of unrelated to this talk, and then other kind of other GI conditions and other things. And so, this really kind of helps to kind of get a sense of what things, may be important and may be drivers of some of the COPD mortality that's seen. So I've talked about pulmonary vascular disease, and so the next couple of minutes, we'll just talk about what exactly do I mean when I say pulmonary vascular disease. And so this is, there's two different circulations in the body. There's a systemic circulation and a pulmonary circulation. This is what the circulation that goes from the right heart to the left heart. And so, any kind of loss or remodeling that happens here, can result in pulmonary hypertension. And for most of the patients with COPD, it's classically been thought that all of this happens because of hypoxia and the loss of and small vessel loss and hypoxic vasoconstriction. But over the last 10 years or 15 years or so, really started to identify that some of these vascular changes are occurring in milder disease, and it's not something that's just exclusive for end-stage lung disease. And so, similar to the previous picture, some of the comorbidities that are associated with pulmonary vascular disease are things like congestive heart failure, sleep apnea, pulmonary embolism, things like that. But there's a lot of other work that's been shown that inflammation and direct endothelial dysfunction may contribute to this pulmonary vascular phenotype. And that within COPD, pulmonary hypertension is independently prognostic for different things. And then just to make sure that that everyone understands pulmonary hypertension. So, pulmonary hypertension is an abnormal, abnormally elevated pressure in the pulmonary circulation that's associated typically with elevated pulmonary vascular resistance. And this was redefined last year, kind of at the end of last year. And so, from a previous definition to maybe include, some additional patients based on findings that any kind of abnormal pulmonary pressures carry some prognostic importance. And so when we think about this, typically we think of what's called a precapillary pulmonary hypertension. And so this is where you have an elevated pulmonary artery pressure. So that's what the MPAP is, the mean pulmonary artery pressure. So it's over 20. The old definition was this pressure needed to be over 25. And then you need a normal or pulmonary arterial wedge pressure. So that's indicative of left ventricular filling pressures. And so if this is normal and the right-sided pressures are high, and then you have an abnormal pulmonary vascular resistance, and that's considered a precapillary pulmonary hypertension. The other two categories are postcapillary pulmonary hypertension, and essentially those are typically left ventricular disease. So things like congestive heart failure and cardiomyopathies and things like that. So when we think about COPD, it falls into this clinical grouping of three. So Group 3 is due to chronic lung disease or to hypoxia. So COPD is not the only one. Other diseases, interstitial lung diseases, and cystic fibrosis and things like that fall into this Group 3. And so that, so that does differentiate it a little bit from what we think of as pulmonary arterial hypertension or idiopathic pulmonary hypertension, and that's Group 1, and that's the one that medications like vasodilators and endothelial receptor antagonists have really been extremely beneficial. And so I mentioned, just to kind of contrast that a little bit more, so the idiopathic pulmonary hypertension, or PAH, or this Group 1 PAH that's shown here on the right side of the cartoon, this is the classic pulmonary hypertension. This is phenotypically and mechanistically different. Where you can see here on this cartoon of the cross section of the pulmonary vessels, it's really characterized by this proliferative endothelial cell lesion, and these are called plexiform lesions. And so it just basically obliterates the pulmonary vasculature, which leads to the remodeling, leads to the altered pressures, and ultimately RV failure. If you contrast that to highlanders or people who live at high altitudes, you don't see this abnormal proliferation. Instead, you see smooth muscle hypertrophy and some smooth muscle proliferation as well. And a lot of that is due to this remodeling that occurs because of hypoxic pulmonary vasoconstriction. Now, COPD falls in the middle because you get some characteristics of this smooth muscle proliferation and smooth muscle hypertrophy, similar to what you would see related to hypoxia, although you get a lot of alveolar destruction and capillary destruction and inflammation related to cigarette smoke and other means that lead to this sort of hybrid vasculopathy that occurs. And so the main takeaway from this is that the pulmonary vascular remodeling that occurs in COPD is different than what occurs in idiopathic pulmonary hypertension or PAH, and that will have consequences as far as therapeutics. I mentioned earlier that capillary destruction occurs in COPD, and this can lead to kind of this loss of cross-sectional area. And so this is some work that we did several years ago in COPD Gene, which COPD Gene is an NIH-sponsored observational cohort of 10,000 smokers and patients with COPD that have been prospectively followed now for close to 15 years. And they all had CT scans and pulmonary function tests and did questionnaires, and all had genetics performed. And so what you can see here is, these are two patients that are both kind of in the same category of COPD based on their FEV1, but you can see this patient on the left-hand side, the diaphragms are domed like they should be, the lung parenchyma look okay, and below it, when we've done vascular mapping, you see that the whole vascular tree is present, and so you have lots of these small intraparenchymal vessels. Contrast that to the right, where you have these large areas of emphysematous destruction, and you get hyperinflation of the lungs, which is characterized by this flattening of the diaphragm. And then when you look at the vascular tree, you see a lot of dropout of these small intraparenchymal vessels, and this kind of follows the loss of these alveolar units that occur from emphysema development. So other things that can occur, I mentioned earlier tobacco smoke. So there are mechanisms for direct endothelial dysfunction related to reduced nitric oxide synthase, as well as to altered expressions of VEGF and other growth factors. there is an increased infiltration of inflammatory cells, and some different pathways are activated there, as well as some changes in progenitor cells. And so these are two pathways that have been pretty well described. One of them here on the left is actually done in a mouse model, and then kind of validated in some end-stage COPD patients with and without pulmonary hypertension, shows that extracellular matrix breakdown. So the extracellular matrix that surrounds these pulmonary vessels can result in hyaluronan deposition, which ends up recruiting a lot of inflammatory cells, and as you know, can lead to this vascular proliferation and this smooth muscle muscularization of these arteries. And on the right, just IL-6 has probably been one of the most classically characterized cytokines that's been associated with vascular disease or pulmonary vascular disease and COPD. And so, this figure just kind of sums up kind of the general findings is that, cigarette smoke can increase IL-6 levels. And then, these levels tend to be higher in patients with COPD compared to non-smokers. And then those that have pulmonary hypertension, IL-6 levels are even higher. And so this is kind of, is probably the most widely known association with inflammation in COPD. And pulmonary hypertension. I mentioned that, because these patients and, have this abnormal, blood flow in the lungs and these increased pulmonary vascular resistances, and can ultimately lead to right heart failure, there are associations, not surprisingly, between the degree of pulmonary hypertension, so how high is the pressure, and a reduced exercise capacity as measured by a 6-minute walk distance. And so these were a group of patients that all had severe COPD, meaning their FEV1s were less than 50% predicted, but they were all, across all groups, their lung function was relatively the same between groups. So this was something that was sort of independently associated with the underlying vascular disease. And similar, patients with combined COPD and pulmonary hypertension have an increased morbidity, so shorter time to first hospitalization for a COPD exacerbation. And you can see here that this is, this is the mean pulmonary artery pressure. They use different nomenclature, different thresholds back 20 years ago. So, so some of this, I think the concepts are still true, even though the raw numbers may be slightly different. And then similarly, pulmonary hypertension, the degree of pulmonary hypertension was associated with excess mortality. And if you look at what the hazard ratios, the different comorbid conditions and other associated conditions, things like metastatic cancer, weight loss and cachexia, things like that, those really carry a high risk for mortality. But pulmonary hypertension is just sort of right underneath those. And then also the degree of pulmonary hypertension matters. So with the higher pressures, the worse the overall survival. I mentioned sort of at the beginning of the talk that for a long time the main school of thought was that pulmonary hypertension almost exclusively occurs at end-stage lung disease, so in those patients that require home oxygen. But that's not really the case. So there is a unique phenotype of patients that are considered out of proportion pulmonary hypertension, and these have a reduced survival. And this is in patients that have relatively normal lung function measured by pulmonary function testing, but they can have very severe hypoxemia, and they have a compensatory hypocapnia, so they tend to have a high respiratory rate, and then their diffusion capacity is extremely low. And so when they looked at these, this out of proportion group really had a significantly reduced survival. So I've sort of painted the bleak picture of pulmonary hypertension and COPD, and so the next sort of area that I'd like to talk about is, how exactly is it diagnosed? We kind of talked about the diagnosis with hemodynamics, and so right heart catheterization, which is where they stick a catheter with a balloon on the end of it in the neck or in the groin, and run that through the right ventricle and into the pulmonary circulation, and inflate the balloon and measure those pressures. And this is something that's done pretty commonly by cardiologists and some pulmonologists at different institutions. And it's really used to guide therapy for group 1 pulmonary hypertension. It's not used that frequently in COPD for several reasons, because there is some associated morbidity. It's an invasive procedure. There's a risk of bleeding. There's a risk of more catastrophic complications, ruptures and death and other things. And then that's, those risks are really, not offset by any benefit. So, to kind of foreshadow some of the end of the talk, there's really not been any treatments that have been proven to be effective for pulmonary vascular disease or pulmonary hypertension and COPD. And because of the lack of consistently doing these tests, the estimates of pulmonary hypertension and COPD as measured by right heart cath have varied from 10 to 90%, which is, I think, means that nobody really knows what the actual prevalence in the population is. And so because those tests are not done, there's a lot of interest in using non-invasive testing. And so some of these tests include echocardiography or echoes. And so these are a non-invasive ultrasound-based tool that you can use to assess the heart as well as the pulmonary vasculature. And it gives an estimate of the right ventricular systolic pressure, or the RVSP, or sometimes it's called the systolic PAP or SPAP. And these work relatively well in patients with normal lungs. But in patients with COPD, it's very difficult to get a good acoustic window. So these ultrasounds rely on these waves bouncing off of other internal structures and lung parenchyma and things like that. And when you have big pockets of emphysema or hyperinflation, there's nothing for the ultrasound to bounce off of, and it really disrupts the signal, and you can't get an adequate window. But what's been shown is that if you can get that window, it correlates pretty well to invasive measurement. So the echoes are not bad, they're done, but if you can get an answer for the RVSP, then it's probably pretty reliable. But in the majority of these, we're unable to get that. And that's the case, even here at UAB, where we have highly skilled technicians and cardiologists and things that are doing these. So it's not really that practical for COPD. Cardiac MRI is one of the emerging modalities that has been looked at. It's something that we're using now, and others. There's different methods using these cine images on cardiac MRI that have been shown to associate pulmonary artery stiffness, and kind of using contrast and seeing kind of how the flow is through the pulmonary vasculature. It's been associated with different cardiovascular events, including mortality from VTAC or heart failure or CV related mortality, and has pretty good sensitivity and specificity. So the issues with, you know, that we see with echocardiography are not really present in cardiac MRI. You know, working with our group here, we've developed this other sort of alternate method of it's called a velocity transfer function. That just it's a non-invasive way to measure cardiac impedance pulmonary vascular impedance that really correlates with pulmonary vascular resistance and right ventricular function. And we've looked at a pilot study of patients with COPD and have shown that it's also independently associated with a shorter 6-minute walk distance, even when adjusted for FEV1. And so, so these, cardiac MRI is a very good tool. The main limitations of cardiac MRI are, the availability. So there's not a lot of centers that have cardiac MR. Also, there are weight limits, which, we run into in Alabama, not infrequently. And then there's other issues with, claustrophobia and other things that people may not want to be put into a tight little tube for an hour. And so it's, most of our interest has been in CT imaging. And so there's two different things that you can look at. So you can look at the main PA diameter or pulmonary artery diameter, and then you can ratio that to the ascending aorta. And so the PA diameter, it varies based on body habitus, body surface area. It varies by sex, and it also is dependent on how the CT scan algorithm is. Do they use contrast? What is the thickness of the cuts? How much radiation is given? All of these things can affect the PA diameter. But if you ratio it internally to the the diameter of the ascending aorta, it really adjusts for all of these things, and it's been it's more improves its repeatability. And so these are just some reference values that have been around for quite a while, in several different studies. And then these are pretty reproducible when you either within the same observer or between different observers. And so this is kind of a cartoon of kind of what this looks like. And so on here is a normal axial chest CT image. So this, just to orient you, this is the participant's back, this is their chest, and then the black areas here are their lungs, and then this is the mediastinum and the pulmonary vasculature. And so the blue is the pulmonary artery. So this is the main pulmonary artery here, and then it bifurcates into the left and the right pulmonary artery. And then this is the aorta, the arch of the aorta as you see it coming up and then going down into the descending aorta. And so on a CT scan, this is what you actually see, and then this is how the measurements are done. And so we were some of the first to really look at this metric in COPD, and you can see that the pulmonary artery size, when it's increased, that when the diameter is increased, I guess we call it pulmonary artery enlargement, and that's where the PA is larger than the aorta diameter. And we've shown that in patients with severe COPD, that this correlates really well to invasive hemodynamics. So very similar to echocardiography, that the PA diameter alone, as well as the PA to A ratio, were correlated. And then when we adjusted this for demographics and the presence of heart failure and resting hypoxemia, we found that in independent models that the PA to A or PA enlargement was associated with the mean PA pressure as well as pulmonary vascular resistance, but wasn't really associated with any of the left ventricular measurements, which was reassuring. And then if we look at the echocardiography, it was not really associated with the invasive mean PA pressure, but it was associated with pulmonary vascular resistance. So in our models, the PA to A or PA enlargement, it didn't have great sensitivity or specificity, but had a decent accuracy, and it did outperform echocardiography for diagnosing pulmonary hypertension. And so we've been using it and really have spent a lot of time looking at what defines PA enlargement. And so, there's a lot of different things, genetic conditions, lung conditions, heart conditions, inflammation, et cetera. And so from some of the work we did in COPD gene, where we had 3,400 patients that all had GWAS, we found that there were two hits with two genes that were independently associated with PA enlargement and pulmonary vascular remodeling. And so this gene on the left, IREV2, is an iron receptor binding element, and that's been associated with hypoxemia. It's associated with inflammation, and it's popped up in a lot of these different genetic association studies in COPD. And so it's probably a more conserved, or not conserved, but it's a gene that's frequently implicated in various aspects of COPD. This other one is a galactoceramidase, I believe, and this one is typically associated with Krabbe's disease or one of these glycogen storage disorders, but it's been involved in or implicated in angiogenesis and some other things. So there may be some vascular, some true vascular, signaling that may be related to this, but it's not really been shown outside of this study. Moving next to the airways and the lung parenchyma. This was a study by a different group that looked at the PA to A ratio, and then looked at was this just a function of emphysema, or is it a function of airway remodeling? And they found that really there were no differences in the PA diameter compared to emphysema, but there were some associations with airway remodeling, which was using one of these CT scanning metrics called the PI-10, and then there's also associations with hyperinflation and as a measurement of kind of an indirect measurement of lung function impairment, but there were no again, this was a different study, and there were no associations with emphysema and PA enlargement in this study as well. So it does seem like that emphysema does not necessarily, it's not associated with PA enlargement, but other things, airway remodeling and hyperinflation may be contributing to it. I showed a picture of this vascular pruning earlier. It's related to, typically related to emphysema. However, if we, what we've shown is that, as you get this intraparenchymal arterial pruning, so as you lose this small, as you lose these small intraparenchymal vessels, there's this centralization of blood flow and centralization of I guess where the blood volume is stored, that leads to this larger vessel remodeling. And so, this in panel A is kind of this normal PA to A ratio, and this is the same participant. You see that they have all of their intraparenchymal vessels, and here on the right, you see that there's obvious PA enlargement here, and that there's a pretty significant loss of these intraparenchymal capillaries. And this was these were both in participants that had relatively normal, they had COPD, but had relatively normal lung function. And you know, using some of these different measurements for these small vessels, both the total blood volume and the BV5, which is cross-sectional area of these small blood vessels with a cross-sectional area of less than 5 millimeters, were both inversely associated with the P/A ratio. Moving on from just kind of how does PA enlargement happen to why does it matter? And so, you know, when we've done a small pilot study looking at CT scans and cardiac MRI in patients with moderate COPD, so an FEV1 of over 50% in general, and you know, who hadn't exacerbated and who were, you know, otherwise relatively similar. And what we found is that of those, about a third of them had PA enlargement. So again, these are very small numbers. And PA enlargement in this group was associated with abnormal right ventricular size and right ventricular function. And so these are things that would be subtle enough to not be recognized clinically. And so it does suggest that the PA to A ratio or PA enlargement, you know, maybe identifying some people that are going to be at risk for events later on downstream or over time. And we've in work that we did in COPD gene and in the Eclipse cohort, we found that PA enlargement predicted severe COPD exacerbation. So these were events that were characterized by hospitalization. And so, this was somewhat of an unexpected finding, but it's been actually an extremely reproducible finding in these cohorts and others. And so, and so once and so it was really pretty interesting that, once there is this abnormal vascular remodeling, so once the P to A ratio is over 1, there's a really steep increase in the percent of study participants that had a COPD exacerbation, either a severe exacerbation, either within the year prior to enrollment or in longitudinal follow-up. And we went on to adjust, to do some adjusted models, logistic regression models, to look at, these associations for exacerbation, the severe exacerbations, adjusted for, all demographics as well as other factors that have previously been shown to be extremely important for predicting COPD exacerbations, and found that the P to A ratio had the highest odds ratio for severe exacerbations, and this was validated in a separate cohort. So this was in over about 5,000 or so patients or study participants. We've gone on to look at, is this P to A ratio that's characteristic of this pulmonary vascular phenotype, is it a static measurement over time, or is it something that's dynamic and changes? And so this was a retrospective look at some patients that were hospitalized here at UAB with COPD exacerbations. And what we found is, not surprisingly, patients that had congestive heart failure or known pulmonary hypertension or that used oxygen were more likely to have PA enlargement, even though some of those didn't reach statistical significance. But we did find that during an exacerbation, the PA does enlarge a little further, but then in about a third of the patients, we had a follow-up CT scan a year later and found that the PA size had kind of returned to its baseline value, which was pretty interesting. in this same cohort, we did find that patients that had PA enlargement were at increased risk for cardiac injury. So they had an elevated troponin, which is characterized, or which is, if you think about as myocardial injury, or oftentimes a non-ST segment elevation myocardial infarction. And then we found that having PA enlargement and a positive troponin or marker of cardiac injury were associated with increased risk for respiratory failure, ICU admission, and in-hospital death of these patients. So again, this sort of underpins the importance of this pulmonary vascular phenotype, and that may partially explain why these patients may not respond to antibiotics or steroids at the time of their COPD exacerbations. We have also shown that the PA enlargement is associated with development of incident hypoxemia over time. So this was another study in COPD gene, kind of a subset of about 670 patients that did not have hypoxia at baseline, and then at 5 years later of follow-up, found that PA enlargement, in addition to some of these other factors, were associated with the need to use supplemental oxygen. And then we've also shown that there's an association between PA enlargement and survival. I don't need to go through this chart, and again, these same participants from COPD gene that have mortality adjudicated, so it's just all-cause mortality. Unfortunately, we don't have cardiovascular or lung-specific mortality. But we found that those with PA enlargement had an increased risk of death, and that even when adjusted for other factors felt to be associated with mortality, there's still a 44% increased risk for death in this group, also characterized by a shorter mean survival time. We have kind of expanded just looking at the PA to A ratio by also starting to link some of these intraparenchymal vessels with cardiac remodeling, really trying to dig into this heart-lung interaction that we're seeing in COPD. And what we found is that the loss of intraparenchymal vessels, when coupled with RV remodeling, and so the RV here is shown in blue and the left ventricles in red. So when you have this RV remodeling, you have this sort of loss of intraparenchymal vessels, and those patients have a lower survival. This has also been shown in very severe COPD in patients that are undergoing lung transplant evaluation. And so really, using these CT techniques can help to identify patients that have this different phenotype within COPD that really can be different as far as potential response to therapy or different disease course potentially. And so one of my other areas of interest is really trying to think about different pathways and really trying to think about what we can use to influence the natural history of this condition. And so this is kind of an older article that really depicts a lot of the major categories of therapy for pulmonary hypertension. And so this is group 1 PH. So there's vasodilators, with all the endothelin receptor antagonists and other calcium channel blockers and things, anti-inflammatory therapies, prostacyclin inhibitors, NO donors, some of the endothelin ones, prostacyclin analogs, anticoagulation, remodeling therapies, and then inhalational therapies. And so There's been a lot of work put into really trying to identify, which of these may work in COPD. And unfortunately, a lot of the, vasodilators and anti-inflammatory therapies and other drugs that have been looked at have failed. And so really for patients with COPD, we're left with treating them with oxygen, which to me is not the ideal situation. And so I think there's still a lot of work to be done. And this is where I think we can use, PA enlargement to really help to tease out, who may get a differential response or to enrich for clinical trial enrollment. And so just to kind of wrap up some of my thoughts here for the talk, I think that, we really need to think about COPD as this sort of, multiple orphan disease state, and that complex heart-lung interactions really affect the outcomes, and that COPD is more than, just something that needs inhalers and antibiotics and steroids. And that the pulmonary vascular phenotype is pretty common in COPD, at least based on the CT scans and things that we've done. It's probably, accounts for about it's present in about 25% of the overall COPD population. And that combined COPD with pulmonary hypertension is a really bad thing. It's associated with COPD exacerbations, disease progression, mortality, and that there's a lot of different pathways that are implicated in how it develops, and it does develop in a different way than group 1 pulmonary hypertension does. And that, we can use non-invasive imaging to assess pulmonary vascular disease, and this is something that's a very useful research tool, and it's also something that's been easily translatable to the clinical space, and so it's something that's been adopted into clinical practice. And that PA enlargement is it's been shown to be very important from a prognostic standpoint for disease progression, exacerbation risk, and mortality. As I just mentioned, I think this may be a useful metric for phenotypic enrichment for clinical trials that are considering some of these new potentially targeted therapies for COPD and pulmonary hypertension.